Hello, everybody. This is Farahati. I'm using Health Economics book, 6th edition by Santur and Noon, and this is chapter 4, Healthcare System and Institutions. Lecture 1, you will learn about the system and reimbursement in the healthcare system and in institutions. In this chapter, you will learn about the key elements of healthcare system. Like any other product and services, we define healthcare system which deals with the production, consumption, and distribution of healthcare services in a society. So, like any other product and services, we always like to look at the product and services from the supply and demand side, and from the production and consumption and distribution of that product or services. Now, how we can determine different types of healthcare system by looking at the structure of healthcare system and answering the following 3 questions. So, the first question is what medical goods to produce, and then the second question is how to produce, and the third one is who should receive medical care. These 3 questions and by answering these 3 questions, we can actually determine the structure of the specific healthcare system. Now, let's go a little bit in more detail. There are 3 common, essential, and deeply intertwined elements which are critical to all healthcare success. So, first, we look. The 3 elements are financing, and then the second is delivery, and then the third one is regulation. So, in the financing, we have to answer the questions of who pays to whom, how they pay, how much they pay, and what they pay for. In the United States, healthcare is financed or paid for a variety of ways. So there is no one way of making decision about who pays to whom and how they pay and how much they pay and what they pay for. So we have different actually financing reimbursement based on the type of the insurance we have. Basically in 2016, starting with the total population of 326 million people, from that number, we have a majority of the people they actually covered by employer sponsored insurance. Either they are employed or they are actually dependent family. They are under the employer sponsored insurance. 160 million people. These are non-elderly people. So the majority of people are under the employer-sponsored insurance. And then we have the individually purchased coverage, about 33 million people. And then we have the Medicare for elderly and disabled, which are about 46 million people. So these are elderly, mostly they are elderly, and there are some disabled people that they are permanently unable to work. So therefore they are under Medicare and also Medicaid. We will say that dually eligible for both of them. Medicaids are for poor people, and they are about 60 million. So these are basically every 2 years they have to prove their eligibility. Therefore, so those people that are permanently disabled, they actually fall in both of them. So they call that dually eligible in both Medicare and Medicaid. And then we have VA for veterans, which there are actually different years. That's why I didn't put the number here. there are about 29 million people without insurance, which actually accounts for 9% of the total population um, right now after the ACA. This percentage was about like 60% before the ACA. So first, so this financing actually and reimbursement determines basically one of the elements in any country, what type of healthcare system, a structural healthcare system each country has. The second key element is the delivery, what care is provided to whom and by who. So this is the private and public providers, including basically hospital, physician, nurses, technician, etc. And these are the providers basically, by answering the question what care is provided to whom by who, then we can actually determine what kind of healthcare system we have. And also the regulation tells us who sets the rules and what rules do they set. In the United States, we have both public and private organizations. They set the rules. And also these rules are varied across the geographies and population in different states. They have different basically rules, but generally the only universally a single payer we have is the Medicare for elderly and disabled, which are the rules are set by federal government, the Medicaid, and all the other insurance. The Medicaids are basically set the rules by both federal and the states, and all the others basically they are different based on the state's region of residence and the sociodemographic, that age and income, and of course gender. Now, when we again try to look at the elements of a healthcare system to determine what kind of healthcare system we have, and whether we have the right basically healthcare system or not, this is a normative statement that entails value judgment. If we wanted to decide whether centrally ruled healthcare system is better than decentralized one, you can actually list the pros and cons, but at the end, again, it's very difficult to make a decision which one is which one preferred to the other one. In the centralized healthcare system, the choices are decided by a government or a central authority. So the pros is that is more capable of distributing outcome more uniformly. So we have equity here and has a greater ability to exploit any large size economies. So the cons, on the other hand, lacks a competitive incentive to innovate because whether you work or not, you have insurance, health insurance, and in a centralized basically economy, you're covered basically if you work harder or even if you don't work. So basically this doesn't give you any incentive to work harder and compete. So therefore, most of the R&D pharmaceutical companies are in the United States because they are supported by the R-free economy. Another cons is this centralized system. They faces high cost of collecting information about the consumer needs. So they have to basically make a decision about all the production. So that actually takes a lot of administration costs for collecting the information, and because in a free economy, the invisible hands, we say that invisible hands means that the production and consumption, they interact and determines what is profitable, and then that actually invisible hand direct the producer to produce more or less based on the consumer's demand. But in a centralized economy, all these basically information should be collected by the centralized system, and that's very costly. On the other hand, those people, they are basically against the centralized system. They say that the decentralized system, the individual consumers and healthcare providers basically interact in the market, which the best example would be the United States, and determine the demand and supply interact and determine how much should be produced and consumed and with what prices. So we call that invisible hands, because this interaction of the suppliers and consumers determines the equilibrium point for consumption and production, and the equilibrium for price. Now, the pros for decentralized economy may they say that this economy provide more alternative and innovation, basically, because it gives you this incentive to work hard and to come up with the new ideas. The cons against this decentralized economy is that are that basically they incurs high cost due to the economies of size, non-uniformity, and lack of coordination. So basically, we are dealing with inequality. So when we talk about economies of size, some of the superpowers, they get stronger, and the small businesses, they can't actually compete with them. So some of the big powers, they monopolize the market, and therefore we deal with the inequality, and which is not fair at some point, because some people basically cannot compete, and therefore so they can't have a basic human rights, which is basically the basic healthcare that everybody is basically need. So these are the cons for this decentralized system, or a free system, market system, that the best example would be the United States healthcare system. So the healthcare system are huge, complex, and constantly changing to respond to the basically consumers and producers changes over the time. Basically, we have economics forces, we have technological forces, and then we have social forces and historical forces. So, but usually the demand for medical care changes by when the national income per capita changes, right? So you demand more, of course, with a higher standard of life, you spend more in medical care, especially in the prevention. And when we have a recession, definitely we don't have even enough resources for treatment. So forget about the prevention. The technological forces, especially we are talking about the medical technology, they are actually making the medical care cheaper and basically more available for people. So it's the quantity increase, and then basically with the lower prices. Um, and the social forces are depends on mainly some of them depends on political forces, and they are changing the demand and supply, the production and consumption, and distribution of the healthcare system. And then we have the historical forces. Basically, there are combination of all these changes. They basically determine how much we have to produce, how much we have to consume, and how to distribute them. For example, currently we have about 900,000 physicians, 2 million nurses, and 6,000 hospitals, and 80,000 nursing home. Now, for the next future, basically for the next 10 years, we have to decide how the demographic and epidemiology and economic changes are basically changing our production and consumption of the healthcare system. We have to make a decision from right now for the next 10 and even 20 years. How many students, how many medical schools we have to create, and how many physicians in different specialty we have to train, and how many nursing home we have to basically create from right now for the next 10 and 20 years. So these are all depends on so many factors: economic, technological, social, historical, epidemiologic, socio-demographic, basic factor that should be considered. Um, then we have these. If you wanted to show a model of healthcare system, this is a general in any general healthcare system. We have a triangle-shaped diagram that shows the three major players in any healthcare system, either centralized or decentralized, basically. So there are three major players in any healthcare system. So definitely the first one would be the patient or consumer. So that's the first thing. Basically, it's there, and then create the other two other actually major players. So when we have the patient or consumers, then we also have we need the healthcare providers, which are the physicians, hospital, or basically any providers in healthcare, in medical care. Now, we need a third actually party payer. Why? Because in health care, you never know when you need treatment. Most of the cases, you don't know when it happened that you need that in case of treatment, and how much you need is. And so basically, the price and quantity and the time and basically amount of the treatment are all basically question mark. You have no idea. That's why so the people they need a third party basically to cover them, so they are willing to pay for example to the government through taxes or through their basically employer insurance to have as a premium to have insurance to cover them um, um, when they need basically medical care. So this premium, so that's the financing for this premium. Basically, could be paid to the party payer, and that is different. It depends on the type of healthcare system we have. Now, so the people basically they pay a premium, and then in return they get a peace of mind that if something happened to their health, they are covered. So, so the point here is that what we are trying to figure out in economics, these premium and out of pocket are very important for production and consumption of the healthcare medical care. So that's what we are trying to figure out. What is the optimum point, optimum amount for the premium and out of pocket to avoid any misconsumption of the medical care. So it is important actually to think about that. If you pay a low premium but have a huge basically coverage, definitely you're going to misuse and overconsume the medical care. But if you have to pay for each additional basically medical care, you have to pay out-of-pocket fees. So that actually prevents somewhat you misconsumption from the overconsumption of the medical care. So that's why in economics, we are trying to figure out what is the best financing and reimbursement that actually produce in the amount that we really need, but at the same time avoid prevent the people, the consumers, from over consuming, or maybe you can say that misusing that, or basically we say that basically they are overconsumption, and we call that moral basically misuse of the medical care. Now, so in economics, we are trying to determine the role and financing methods of the third-party payer, basically in the best actually amount and best possible way to have the basically the best and optimal point of production and consumption. So the third party payer are private health insurance companies or the government. Are intermediaries between the consumers and the healthcare producers. And remember that the consumers are patients in healthcare system. So these third-party payers monitor the behavior of the healthcare providers as a means of controlling medical costs, and or we say that medical utilization, medical care, and then these third-party payers are responsible for managing the financial risk associated with the purchase of medical services. Again, remember that what makes the healthcare system different than the other products and services, the basically a lack of information about the time of the treatment and the price and the quantity that you need. So those are the factors makes medical care different than the other production and consumption in the other product and services. So why do we need the third party payers? Because of the lack of information about the time, the quantity, and price of the medical care when you need. So you wanted to have a peace of mind. So in that case, you accept to pay monthly to a private health insurance company, as a premium in exchange for some agreed amount, open agreed amount of the medical insurance coverage. So the monthly premium usually is different, depends on the coverage you get, and depends on so many other factors. Of course, the insurance company, they look at your socio-demographic and region of residence and so many of other factors that we talk about that later. Now, the government, the public health insurance company, also financing medical care insurance comes from taxes. So the private health insurance, they charge for premium, and then government and public health insurance company, they basically get their premium from taxes. So the main basically public finance, remember that comes from taxes. So that's the main one. Now, if based on your insurance, we wanted to know that what kind of package you have. So we have to look at the risk management, reimbursement, and consumer cost sharing. So the first factor or variable you look at, it's reimbursement, could be fixed payment. If the reimbursement, based on the insurance package you have, is a fixed payment, then this is independent of the amount of medical services actually provided to patient. So it doesn't matter. From the beginning, your package is fixed payment, and if the actual cost is less than the fixed payment, so there is a surplus kept by the healthcare providers. And if the actual cost is greater than the fixed payment, so then cost overruns incurred by healthcare providers. So depends on the package you have. This fixed payment reimbursement determines basically who get basically more, who get less. And we talk about that, if that's good or bad. Now, if the reimbursement based on the package you have is a variable payment, now this varies with the amount of the medical services actually delivered to patient. So sometimes we have a retrospective reimbursement, means that it bills for actual costs incurred, generated by the healthcare providers. And then sometimes this variable is based on the fee-for-service payment, so a price paid for each unit of medical services. We are trying to compare these different reimbursement in different insurance package and figure out which one of these variables are preventing us from overusing the medical care, and which one is basically helping us to have an optimal point for production and consumption. So this is actually a matrix which actually shows important information about the risk sharing and incentive for consumers and producers of medical care to produce and consume in the amount of medical care. In the top here we have the type of reimbursement, which whether the reimbursement is a fixed payment or variable payment. And then in the vertical axis we have the out-of-pocket price to consumers, whether the consumers have to pay low out-of-pocket or high out-of-pocket, depends on the fixed payment they have or variable payment. This determines the consumers and producers basically behavior in the market, how much they produce. In the first place, when the consumers have to pay out-of-pocket price to basically it's very low out-of-pocket price, and you wanted to go to the doctor, physical therapy, and your out-of-pocket here maybe is $5, and there is a fixed payment of means that basically in that case is covering your coverage. There is a low likelihood that you overconsume the medical care compared to the time the out-of-pocket price consumer is low, but there is a variable payment. In that case, if your coverage is covering higher, the producer basically covering more, the type of reimbursement, so there is a higher likelihood that you definitely consume that physical therapy with the $5 out of pocket. You probably go every day to that physical therapy compared to the time when you have a fixed basically coverage. In that case, there is a low likelihood that you overconsume the medical care. In the case you have a high out-of-pocket, so if you're out-of-pocket, instead of $5, you have to pay $50 for the physical therapy. In that case, there is a very small likelihood that you overconsume or misconsume the medical care. But if there is a high out-of-pocket, but you have a variable payment here, so in that case there is a higher chance, the coverage basically you may actually use that more than usual. So the best case scenario is when there is a cost sharing basically in the demand and supply in the market, that to reduce the potential for excess medical services. So here we have this a very low likelihood of excess medical use of excess medical services when we have a high out-of-pocket price, and also there is a fixed payment of coverage here. So in that case, so the best case scenario is that definitely you have to have a cost sharing by having an out-of-pocket price to give this incentive to the consumers, to the patient, to not to overuse the medical services, and also there should be a specific coverage. You can actually use the medical services in the optimal point.